Everybody, good morning, good afternoon, and good evening from wherever you are. My name is Wendemagegn Enbiale. I'm a professor of dermatology and a medical doctor by training, with specialization in public health and PhD in global health. And my research topic is usually on anesthesias, especially focused on skin anesthesias. Today, we are joining us as part of the week is a Fungal Disease Awareness Week from September 16 to 20. And DNDi and CDC have organized a webinar focused on mycetoma, a neglected tropical disease that causes a devastating disability and death. By bringing together a leading expert on the subject, patient advocates, and healthcare professionals, will be speaking about the hidden toll of the disease on the patient, out of the challenge of diagnosis and treatment and the disease, and the path forward in relation to research and advancement and the future of mycetoma control. In this panel, I'm joined by 4 distinguished speakers. Each of them, they will have 10 minutes to present from the clinical condition of mycetoma to the prevention and treatments. So I'll be first introducing the first speaker, Dr. Augustin Kadima, who is a WHO medical officer, a focal point for mycetoma and human African trypanosomiasis in WHO Africa region, based on Brazzaville. And Dr. Kadima is a medical doctor with master in public health, with over 30 years experience in primary health care, having worked in several African countries with different organizations. He will be talking about mycetoma, cause, symptoms, its global epidemiology, and its impacts on public health. Dr. Kadima, the floor is for you.
Okay, thank you, Professor. And well, yes, that is my presentation. And in this presentation, I will try to make you understand that mycetoma is a worldwide menace. Slide 1. First slide. Next one. Do you hear me?
Yes.
Next slide. Yes, okay. Mycetoma is a new neglected tropical disease added in the neglected tropical disease 2021-2030 roadmap. And it is a chronic, progressively destructive infectious disease of the subcutaneous tissues that spread to affect the skin, deep tissue, and bone. There are different species of bacteria or fungi that can cause mycetoma. Mycetoma is endemic in tropical and subtropical environment, characterized by short rain seasons and prolonged dry seasons that favor the growth of thorny bush, and its geographical distribution is unclear. But in Africa, most of the cases fall between latitude 15 degrees south and 30 degrees north, the so-called mycetoma belt. And the recognized endemic country include in Africa, Sudan, Somalia, Senegal, and other listed here. Next. The global burden is unknown, but the disease is endemic in Africa, Asia, Europe, and Latin America. And mycetoma has enormous adverse medical, health, and socioeconomic consequences for patient, community, and health service in affected area. Next one. There are many reasons for neglected this disease, but the primary is that it mainly affects poor populations in remote area with a lack of trained staff, health facility, diagnostic tools, and treatment. And other factors adding to the neglect are the chronic course of the disease and the poor treatment outcome in a mycetoma. This map shows where cases have been reported in Africa. We can see that some countries in red are outside of the mycetoma belt, but they have reported cases. In red are countries where cases are reported. Next. Epidemiologically, causative organisms of mycetoma are distributed worldwide, but are endemic in tropical and subtropical area in the so-called mycetoma belt, which include, among others, Bolivarian Republic of Venezuela, Chad, Ethiopia, India, Mauritania, Mexico, Senegal, Somalia, Sudan, Thailand, and Yemen. The number of cases reported differ per country. However, at the moment, most cases have been reported from Sudan. In 2022, it was around 4,900, and in Mexico. Next slide. Yes, causative organisms are many, and actinomycetic species include Streptomyces somaliensis, Actinomadura madurea, Actinomadura perelleti, Nocardia brasiliensis, and Nocardia asteroid, while mycetomic agents include Moderator myetomatis, Moderator graysea, Pseudoleishmania boydii, and Leptospira senegalesensis. Next. Clinically, you can see a picture there. Clinically, mycetoma involves the skin, as we said already, and subcutaneous tissue to form the classic triad of hard, woody swelling, painless discharging cyanosis, and presence of glands, which are colony of bacteria or fungus and vary in color and size depending upon the organism. Next. Clinically, we can have other presentations. Mycetoma and actinomycetoma are almost identical with some subtle differences, and their other clinical variants include swelling. Next one. Without sinus, yes. Some other, you have sinus, somewhat we don't have sinus yet. Next. We can go here. We are visualizing the sinus with swelling. Next one. Yes. Now, about the impact of mycetoma on public health, we know that the impact of mycetoma is especially among children and young adults of working age, and the burden of that the disease placed on poor rural community is a public health and socioeconomic problem. For example, the long-term treatment at an affordable price for the poor. Next. Now, as solution, seeking solution, some possible solutions have been identified. For that, in WHO African region, mycetoma was already included in national master plans by country, and globally, mycetoma is integrated into skin NTD framework, and sensitization tools are needed. Next one. even the drug donation are needed. And finally, globally, we say already, and now we need more research, we need networking and innovation to develop effective tool. And I thank you for your attention.
Thank you very much, Dr. Kadima, for timely giving us the highlight on mycetoma. For the sake of the time, if you have any question from the participants, please keep them at the end. We have around 50 minutes for question and answers. So I'll be moving to the next presenter. And our next presenter will be Dr. Dilip Kachwaha, is a renowned dermatologist with 25 years experience as dermatovenerologist, a senior professor at Matuhara Das Matuhar Hospital, MDM in Jadhar, India. And who will be presenting about mycetoma, the case in India. And Professor Dilip, the floor is for you. Professor Dilip.
Thanks. Yes, thanks for the nice introduction. And it's a really pleasure to be here with you. Can you hear me? I am audible?
Yes, we can hear you.
Yes.
You have 10 minutes to present. Yeah.
Yes, I am a senior dermatologist in Dr. S.N. Medical College. And there are 6 innovations to my name, including a vitiligo surgery by name of Jodhpur technique. I'm basically not only the clinician, but a dermatosurgeon as well. So you can Google my innovations. You will find them very interesting and very easy. And for poorly set up country, they are very good. And coming to the mycetoma, I will not go to the topic covered by previous presenter. It is being neglected. It's a chronic disease we all know. And in my experience, mycetoma is neglected in each and every aspect. So it's a neglected disease with a chronic morbidity and including the morbidity. And of course, it requires special attention. That is why we are here. Next, please. My previous presenter had talked about the epidemiology in the world, all over world, but I will be focusing in India and to the region where I belong, Rajasthan. So basically, from different studies conducted in India, the most affected states are Rajasthan, West Bengal, Tamil Nadu, Madhya Pradesh, etc. And Rajasthan is the place where most of these cases are reported. That is around 33.3 per year. And it is followed by Tamil Nadu and West Bengal. Here, the interesting part in India is at some places, the mycetoma is common, and at some places, actinomycetoma is common. So here, the area where I am, it is the mycetoma, which is more prevalent. Next, please. This is a state-wise distribution of the mycetoma and mycetoma. And the Rajasthan, the state where I am is on the north of the India. You can see it, and this is most affected. Next, please. There are different studies on which I included in this presentation, mainly from the Bombay, from the Madras, Rajasthan, and to my Jodhpur. And on basis of this, I can conclude that the mycetoma is the most prevalent, mycetoma is more prevalent in Rajasthan, and actinomycetoma is another part. Next, please. These are the basically 3 major studies from my institution. when the Borna came and with this, with a few other people from DNDi, Dr. K.R. Joshi is a key person who studied this mycetoma in Jodhpur. And the conclusion of his study, I will tell you later on. Basically, our institution is a medical college, so we have a lot of research in this area. And this it is being neglected, but we had tried to find out the cause, and we try to do best for our patient. Next, please. So at present, we are having this is a total 24-year collection of data with us. And out of 178, 106 are a U mycetoma. And in a U mycetoma, the commonest was Madurella mycetomatis, Aspergillus nidulans, and Madurella grisae. And the actinomycetoma was a 66 out of 178, and the Streptomyces somalensis is everywhere. And Actinomadura madurei and Actinomadura piletri, these are the common organisms we isolated from these patients. And in 6 cases, we didn't got any of the species. So basically, being this magnitude 33 patient in my own state only, you can see the perspective of the mycetoma in India. It is basically underreported, late reported, and misdiagnosed. There is a delay. There are so many issues, and there are so many gaps and challenges in the treatment of mycetoma. So I will be discussing that gaps. So next, please. Next slide, please. Yes. I divided in 3 parts: on patient part, on diagnostic facility, and on treatment part. So first, I will be talking on the patient part. Patient, usually the problem is they are not reporting early to the health facility. When it is a painless small nodule, if it is reported in time, the morbidity will decrease like anything. And here, if we can do the things by giving such a possible solutions like education of the early signs of the mycetoma, this can be done with the help of media coverage, education for prevention of the disease, and educating about avoiding thorn prick just by wearing chappals. You know, chappals are footwear, a very cheap footwear that if they wear, if we can include that in their lifestyle, we can reduce the incidence of the mycetoma. And even if they have a thorn prick and they develop a nodular lesion, they should consult to the nearby doctor. And second, on the patient behalf is a poor compliance to the treatment, because and this problem have a possible solution like decreasing the duration of treatment, nearby availability of treatment facility as we are doing in adults, and intensive active follow-up by the supervisors. If we can do this, then the dropout will be very less and a patient will be treated better. On the diagnostic facility part, there is a delay in a diagnosis and which causes delay in a treatment. The problems are not suspected early by MBBS doctors or specialist doctor. We can give them training maybe online, maybe offline, to recognize the early symptoms of the disease. In a 20 to 30 patients, they remain undiagnosed. So this is again a problem. When you are not able to diagnose, then how you are going to treat, even if you feel like that this is a mycetoma. So in these cases, the solution is we can go for a repeat biopsy to perform a deep elliptical biopsy or trephine biopsy, or we can have the new developing tools to diagnose the undiagnosed cases, like PCR or maybe some biomarker or like that. there is a wide field for the research in this area. And lack of coordination between treating specialists, we can bring them in an umbrella, under an umbrella, so that patient can be treated very fast. Radiological diagnostic protocols are not there. We can make all these diagnostic protocols. And longer duration of of the fungal culture report, that takes very long time. And by that time, fungus spreads to the inner tissue. So if we can develop something to reduce this, that will be also going to very helpful. And
Dilip, can we finish within 1 minute? Yeah.
Okay. Coming to the last, availability of effective treatment, though we have itraconazole, but still itraconazole is effective up to 70 to 80% of cases. We can develop a new drug that might help in decreasing the duration of itraconazole. At least right now we are giving 6 months to 1 year of course, and then depending upon the case may go up to 2 years. But we need certainly more effective than itraconazole. Next, please. Now I will show you a few photographs of the patient which we had treated. Next, please. This is all usually, this case treated 6 months for itraconazole. You can see the change. This is again 9 months of itraconazole. You can see the change. Next, please. Next, please. This is 9 months of itraconazole. You can see the sinuses stopped, ulcer healed, and there's a reduction in swelling as well. Next, please. And this, again, this is 1 year of treatment, and this almost healed. And now treatment is stopped and patient is in a follow-up case. So next, please. The conclusion of this is, after identification of gaps, we need to work on a solution that early, prompt and effective treatment is made available, which can reduce the morbidity and mortality in a patient. So what I feel is treatment must be started whenever you have a doubt whether it is a mycetoma or not. Next, please. And this is an acknowledgement to my DNDi and Gurna and all of you, and my team from SN Medical College, head of pathology, radiology, and radiologists. Thank you.
Thank you very much, Professor Dilip. Please, participant, keep your question at the end of the webinar.
Sure,
after 20 minutes.
Sure.
And we'll be coming to you. And our third speaker is Ikahi John. Ikahi is coming to us now with 2 badges, and he is a microbiologist working on mycetoma and the diagnosis, plus also he is also a patient advocate. John, the floor is for you.
Thank you, Professor. So I'm going to present about the impact of mycetoma on patients. Stories from Turkana, Kenya. Let's go to the next slide. So Turkana is found in Kenya, and it borders 3 countries, that is Sudan, Southern Sudan, Ethiopia, and Uganda. Turkana is arid and semi-arid, and the climatic is hot and dry. The economic activity mostly is livestock keeping, fishing, and farming in some areas with irrigation. Next, please. Next slide, please. So the situation of mycetoma in Turkana. So far, what we know, we have the data from 2019 to 2024. Sorry, go back. So since 2019 to 2024, we have 97 cases and 2 amputation. The estimated prevalence is 1.94 per 1,000 population. Right? So the 97 cases are distributed in all the sub-counties in Turkana, that is Turkana West, Turkana North, Kibish, Loima, Turkana South, and Turkana East. So far, we have 22 patients who are on treatment and follow-up, and the cases might be higher since most of the cases are still unidentified. Next. So the impact of mycetoma on patients, I'm going to discuss the impact in three aspects: the physical impact, economical challenge, and psychosocial impact. Next. So in physical impact, most of the mycetomas have deformities. That is, whenever they have deformities where the swelling is, and sometimes it affects the bones that might lead to amputation. Another physical challenge is mobility. Most of mycetoma patients can't walk properly, so some have to limp, some with aid, such as aiding like crutches. Most of mycetoma patients complain of pain, which is mostly due to secondary infection. And at times, they complain of itchiness due to inflammation of the mycetoma. Next. So in economic challenges, there's a reduction of productivities. This patient who usually used to do their usually work, they can't do it because of the situation, mycetoma situation they are in currently now. So there is reduction of production. They become less productive. So they cannot meet every day-to-day cost. Then dependency for support. Since they can't work like any other, they have to depend for friends and family, and this brings burden for them. And most of them, they can't afford treatment. Mycetoma treatment, especially the mycetoma, need and fungal such as itraconazole, which is expensive for them to afford, so they can't afford. Next. Next, please. The other impact is psychosocial impact. These people or these mycetoma patients are going through. First is most of them feel embarrassed about their mycetoma. Another aspect is stigma. They face stigma in the community. Aspect of social life affected, such as the shoes they wear, the clothes they put on, they have to improvise, and this make them not comfortable in the society. So in working and studying, there is the impact of mycetoma. Some students drop out to school because of the mycetoma. Some stop working. Sports and leisure. Yeah, it's true. Mycetoma affects the sporting and leisure of the patient. They can't do it like the way they used to do in the first place. Another aspect is partner and cross relationship. Most of these patients have lost friends to the extent of partners. Some people have left their family because of mycetoma, and this led to single mothers, so they have to face the consequence of this mycetoma, and which the final is mental health issue. They go through a lot of mental issue and they need psychological support. Next, please. So this is the data we collected about the social impact. So number one, we ask them how they feel embarrassed or conscious, and most of the mycetoma patients, they feel very much embarrassed. A lot said, followed by a lot. They said a lot. Some said a little embarrassed. How the normal life is affected, you can see good number said the mycetoma, they affect their normal very much, followed by a lot, they are little. Although some numbers said not at all. Leisure, you can see at the statistic, most of people leisure is affected very much, followed by a lot, then a little. For partner and close friends, you can see some said very much. They are affected their partner and relationship a lot, a little. In sports, you can see the number is still high. Most I say when the mycetoma affect them very much, a lot. About working and studying, if mycetoma affects their working and study, majority of them said yes. Next, please. So what are the challenges we face in Turkana? So most of the number one is lack of awareness. Most people, they don't know this mycetoma, so there's need for creation of awareness. Another one is poor health-seeking behavior. Most of these people come when to hospital when the mycetoma is really gone.
Sure. Can we conclude within 1 minute?
Yeah, I'm concluding. Limited to access to treatment, there's delayed diagnosis and lack of funds to facilitate. Thank you. Next. So what are our role as a patient advocacy? Our main role is to create awareness. Like you see the poster, we have created poster with mycetoma information and try to distribute it to as many as possible health centers in Turkana. You can see patients come for follow-ups. Usually, I even go to radio to try to create awareness of the mycetoma. Next, please. So to conclude, the impact of mycetoma on Turkana patients is significant, encompassing physical, emotional, economic, and mental challenges. Patient advocacy is crucial in mitigating this impact. And finally, collaboration and research initiatives will enhance better understanding of this mycetoma. Next, please. So this is acknowledgement. I want to acknowledge Cambridge, Turkana, DNDi, Miguel Arandes, and surgery. There's a Spanish surgical team called Surugi and Turkana, which they are doing great work in Turkana. I want to acknowledge my colleagues, Mary, Ogutu, Jimmy Lore, and Kenya Mycetoma Working Team, led by Dr. Ruth, Olga, and the rest. I want to acknowledge Borna for giving me this chance. And allow me to, in a special way, to acknowledge Professor Kika Kolom, who has been working in Turkana since 2019 and has Turkana TAT. Next, please. Thank you for your attention.
Thank you, John, for giving us these insights from the experience from the ground, from the Turkana Center. And we'll be moving for the final presenter. And please remember that we're saving some time, and that means we'll have a lot of time for discussion. So please post your questions into the question boxes. Our final speaker will be Dr. Borna Nyonka. She's head of the Mycetoma Disease in Drug for Neglected Disease Initiative. Dr. Borna is a clinical researcher, medical doctor, and public health specialist. She managed the first ever randomized clinical trials on new treatment for mycetoma in Khartoum, Sudan, which has been concluded just recently. And she also managed the anti-COV trial in Kenya and Sudan, and supported studies in microbial resistance in Kenya and Uganda, carried by the Global Antibiotic Research and Development Partnership, joint initiative by the World Health Organization. Borna is going to speak about the existing knowledge and research gaps on mycetoma, definitely especially on the diagnosis and the treatment, the urgent need for diagnostic treatment and other tools, and the ongoing research for a new treatment in the future. Borna, the floor is for you.
Thank you very much, Prof. Wendemagegn. Next slide. So just to start us off, I wanted to mention a bit about Drugs for Neglected Diseases initiative. The 3 pillars of the organization's mission is innovating to save lives, fostering inclusive and sustainable solutions where we work hand in hand with partners. That is why in this webinar, we have quite a lot of representation from across Africa and Asia, where mycetoma is quite endemic. And we also advocate for change by speaking out for policy change. Next slide. This has already been presented by the previous presenters, but also just understanding on how disabling disease mycetoma is. The burden of disease is quite unknown, except for the mycetoma belt. But as we've been shown, we have quite a number of countries that have reported mycetoma outside this belt. Pathogenesis and transmission is also unknown. So there's still quite a lot of work that is needed in mycetoma. Next slide. Also mentioned are the massive long-term consequences. A priority to mycetoma has not been given before because it is not associated with a lot of mortalities. But what we do know, the morbidities that are caused by mycetoma are usually lifelong, and they have huge psychosocial impact on the families, communities, and health systems, as just presented by John. And also with the physical impairment and the stigmatization, this drastically reduces the quality of life of most of our patients. And of course, with recurrences and multiple amputations with associated adverse effects of this, we also have mortalities associated with the disease. Next slide. So what is DNDi doing to tackle mycetoma? We contributed to mycetoma being classified as a neglected tropical disease by the World Health Organization in 2016. And we also completed in 2022, the world's first double-blind randomized clinical trial for mycetoma in Sudan. Our goal right now is to develop a new treatment for mycetoma that can prevent amputations and disability. We have 4 main areas that we are looking at. The first is the translational research. We are working on the preclinical aspect in the development of a new translational mouse model to be able to guide further our future clinical trials in mycetoma. We are also in parallel conducting clinical studies. We are currently undertaking research in Africa and Asia, where we are conducting epidemiological studies in Senegal, Ethiopia, and also in India. And this is to be able to uncover the mycetoma burden, raise awareness, and contribute to the creation of national control programs. As mentioned, we completed our phase 2 clinical trial in Sudan, where we compared fosravuconazole, an investigational product, to the current treatment, which is itraconazole. Both of these treatments combined with surgery. And in terms of access, after our clinical trial, we are focusing on registering fosravuconazole in Sudan and also developing a global strategy for registration in other countries to promote patient access. Next slide. I will go a bit into the fosravuconazole clinical trial. Next slide. First of all, in terms of mycetoma and why the DNDi mycetoma program is concentrating on this, as also previously discussed, for actinomycetoma, that is a bacterial mycetoma, we have cure rates or efficacy rates of greater than 90%. But from the clinical settings, we are aware that treatment for mycetoma is less than 40%. The most frequent drug that is used for the treatment of mycetoma is itraconazole, but it's quite expensive. The generics sometimes do not have the best quality, and it is not always available. Other drugs such as terbinafine, voriconazole, amphotericin B, posaconazole are also quite expensive. There's limited data available. Amphotericin B rarely used due to toxicity, together with ketoconazole, which was actually banned and removed from the WHO essential medicine list in 2000 with associated hepatotoxicity. Posaconazole has been approved based on retrospective data from 5 patients, but is also not available in these endemic countries. Next slide. We were thus quite willing to be able to work on a clinical trial with a new azole antifungal known as fosravuconazole that had been manufactured by Eisai Pharmaceuticals in Japan. Next slide. Comparing the mechanism of action between fosravuconazole and itraconazole, we find that with the minimum inhibitory concentration, fosravuconazole is 16-fold stronger than itraconazole. It also has very high solubility, which allows for both oral and intravenous formulation, while itraconazole has a very low solubility. Fosravuconazole, which processes to ravuconazole, has a half-life of 8 to 11 days, which allows you to dose a patient once a week, and you do not need to eat any food or drink for bioavailability for fosravuconazole. Itraconazole has a very short half-life, and dosing has to be conducted twice daily. So for a patient with mycetoma, this involves a patient taking 2 tablets twice a day, every single day for a period of 12 months, which can be such a big pill burden on this particular patient. And it needs to be taken after a meal. Considering the populations we're looking at, we do realize this can be quite a huge hindrance in terms of availability of the drug. It also has very limited drug-to-drug interactions, meaning that in areas where there are other concomitant diseases, such as HIV, tuberculosis, it becomes easier to use fosravuconazole. So with this, we were able to use this as an investigational product in a clinical trial in Sudan. Next slide. Where we tried to look at the superiority of fosravuconazole over the standard of care of treatment, which is itraconazole. It involved the patients taking the treatment for a duration of 12 months, and at the 6-month time point, all the patients had surgical removal of the lesion. Then we had a follow-up of 3 months, and our primary endpoint was complete cure at 12 months, where we were assessing clinically to show that there was an absence of mass, the discharge, there was a normal ultrasound or MRI, and there was a negative fungal culture if a mass was present and a surgical biopsy. Due to the socio-political situation in Sudan, and also after the first interim analysis, which indicated that there was no loser fosravuconazole arm, we continued with all 3 arms. And after the COVID pandemic, we had a second interim analysis. After reviewing the data and Safety Monitoring Board indicated that there was no superiority that could be demonstrated, and the clinical trial was stopped at 104 patients. Next slide. From this study, we were able to see that there was no superiority of fosravuconazole arm over itraconazole. So it does seem that itraconazole has good efficacy, but when adherence is completely monitored. So we understand this is not possible in the normal field setting or clinical setting, but within a clinical trial where there's active follow-up from the physicians, from the pharmacists, which involves even taking the medication to the patients in the home, itraconazole can actually have a higher efficacy than previously thought. It was also good to note that fosravuconazole had good efficacy. It had no safety issues, and the treatments were overall well tolerated. So we see with adequate care and access of these drugs to patients, then treatment outcome can be satisfactory. Next slide. So what were the questions arising from this randomized clinical trial? First of all, we need to be able to understand what is more important, drugs or surgery. In areas where surgical excision of the lesion is not possible, what are the options that we have? Because in the randomized clinical trial conducted, all patients had surgery, so we're not able to provide a true picture of the effect of the drug treatment by itself. We were also looking at the mass through the ultrasounds and the MRIs, but we need to be able to measure the total volume better. Encapsulation, we also need to understand what exactly causes the fibrous encapsulation of the mycetoma lesion. Is it the drug, or is it the natural history of the lesion? Then the timing and need for surgery, should we do it before, where we start treatment halfway as conducted in the clinical trial, or at the end of drug treatment, that is 12 months. Next slide. We are looking at approaches to new treatment. We have quite a number of activities ongoing. New compounds are being looked at through the Mycetoma open source pharma program that is led by Dr. Van de Sande and team at Erasmus. We're also looking at research on melanin and manipulation in terms of black grains, such as in Moderator mycetomatis. We're also screening new antifungal drugs for other indications. We have other deep mycosis, such as chromoblastomacosis and sporotrichosis, and trying to see how we can be able to repurpose some of the drugs. But we still need the preclinical studies, as mentioned, to be able to determine the next step for this. New regimes are definitely needed, a shorter duration. 12 months treatment for Mycetoma is very cumbersome, and also has a huge effect on their adherence and compliance, which we have noted has an effect on the efficacy of the drug. Then looking at efficacies of 65 to 75%, we would like to be able to have efficacy of greater than 90% with a safe, oral, affordable drug. And finally, as you saw some of the pictures of the Mycetoma, we usually have bacterial superinfection. So it would be good to also discuss about adjuvant treatments. And also in terms of inflammatory response within the Mycetoma lesion and the fibrosis, how we can be able to modulate this inflammatory response. Next. Thank you. That is it for me.
Thank you very much, Orna, for this brief presentation of what's in the horizon and what has been done, especially on the scientific ground of Mycetoma. And so now the floor is going to be open for question and answers. And there are some questions in the question box, and we're screening them. Before that, I'll come some question which has been extracted from the question box for each of you. My first question will be to Dr. Augustin. Professor Augustin? Kadima?
Yes, I'm there.
Yes. So when you explain about just the global burden of Mycetoma and what's happening, the big challenge for the future when WHO included Mycetoma as one of the NTD, the way forward is actually to have a database, and especially the big challenge is in the future, if we are going to control Mycetoma, we need to have the burden from each country, especially those which we are claiming endemic. And what the work of WHO on this line, and how are we expanding now? Thank you actually for sharing us the updated global map of Mycetoma, but what's happening there? And the second question is, especially with the work going on with Sudan, now with the war, the biggest Mycetoma center is in a challenge of handling those thousands of cases. And is there anything WHO is doing on that? Thank you.
Okay, thank you for your question. It is a very important question. For data, as we are putting accent that the mapping is very important to be done. Last year, already when we push country to put the Mycetoma in a national master program plan, it will push them to have some activity. But already WHO at the global level proposed the GNARF. The GNARF is the Global NTD Annual Report Form. This one, it is ongoing, and all countries are requested to report from this new platform. We will collect data annually from there, but with all our others platform, we are asking country by country to give some information if they have. That's the first thing. And we will catch all opportunity to work with all countries that can give information. Data is very important to collect. That's the first thing for mapping. The second thing about Sudan, it is very, very important. We can't work without peace. We are pushing and we are hoping that Sudan will recover peace quickly, and then our big collaborative center of MRC will work and continue those activities. But we need other country like Senegal, for Francophone country, to be one of the center who we can push to work. And I'm happy to see that even DNDi have some project there. It will be a palliative solution for now, but we are hoping that peace will come, and we will continue to work with Sudan MRC Center. Over to you.
Thank you, Augustin. And I think some of the questions, there are a lot of questions, and if you can't answer them online, you can respond for those. And the next question will go, I think, both for Borna and Professor Dilip. And the first thing is, what are the differential diagnoses, and especially for mycetoma, especially in early case diagnosis, and also for Professor Dilip, what diagnostic criteria do you use in diagnosing mycetoma in your area, and all those 178 cases, are they only from your hospital and countrywide? And the other question is there, from the reported cases, do you have any community-based prevalence studies, or most of the studies are based on case reports? And also on the treatments, what criteria do you use as treatment response? Plus, also, it looks like you only manage them with the antifungal treatments. And the good news about India is the clinical, both the microscopic and also qPCR diagnosis is happening. But are you using surgery? And do you have the experience on that? And first, I'll go to Borna to the early challenge in diagnosis and the differential diagnosis. Thank you.
Thank you. So in terms of diagnosis, first of all, it is usually quite a complicated process, especially for mycetoma. For actinomycetoma, both of them does involve having a biopsy taken and being able to culture the grains or have a PCR to be able to have the causative organisms. For others, even through histopathology, they're able to look at the pus or the fluid and be able to have some of these diagnostics done. In terms of the mycology, that can be quite complicated depending on the capacity of the particular area. But when we have direct microscopy in particular laboratories, this is usually some of the easier methods. Most of the areas that are endemic to mycetoma, unfortunately, do not have these lab or imaging facilities such as ultrasound or MRI that can also be used to provide diagnosis. So quite a lot of empiric diagnosis and treatment is provided. I know for Prof. Wende and also the team, podoconiosis is usually a huge differential diagnosis of mycetoma. But we also have, in later stages of disease, it being confused with other malignant tumors of the skin, of the soft tissue and the bones. And even sometimes when a patient comes with bone involvement and has had an X-ray, we'll have diagnosis of osteomyelitis or even an osteosarcoma that can be provided. So it is good to be able to integrate with the other skin NTDs and other skin diseases, So as we conduct our epidemiological studies, we hope we can be able to integrate all this to be able to pick also the other skin NTDs that are differential diagnosis of mycetoma.
Thank you, Borna. Can you add on what's the importance of, especially if it is EU mycetoma, the etiologic diagnosis? What's the importance if the treatment is not going to be really different? That was one of the questions. Yeah.
So most of the studies that have been conducted, or even the treatment that is currently being applied, which we use quite a lot from the Mycetoma Research Center, is because we do know that the highest causative organism of mycetoma is Moderator mycetomatis. Unfortunately, the other causative species have not been identified, and we have not researched on the impact of the current azoles in terms of the treatment. So even within the clinical trial, we did a PCR to confirm Moderator mycetomatis. So if it is a different causative organisms, we cannot be able to guarantee that the efficacy of itraconazole or fosravuconazole might be the same.
That's the most important thing, I think, for in general in mycetoma, you know that this is there is the EU mycetoma and the acetomycetoma. Definitely we need to differentiate at least between the two, because acetomycetoma is easily treatable with the current available antibiotics, combination of antibiotic. But for EU mycetoma, yes, what we have on our hand is the azoles, and most of the time we are giving them blanketly. But if in the future we are going to practice evidence-based medicine, because you can see that even from Professor Dilip presentations, 70% of the patients respond. In our clinical experience, actually, I think it is a reverse. Most of the patients, not greater than 30%, they don't respond in Ethiopian setting. Recently, I remember Dr. Wasson was presenting, and there was no, from the small patient he has reported, there was no clinical response in most of the patients. And that is maybe because of the difference in those etiologic, the fungal etiology. You know that just in a simple term, different fungus respond different for those azole drugs and glycoflivins and the others. So that's the most important thing. And in the future, we hope that there will be clinical trial which addresses each of those, the dominant causative agents in each region. Thank you. I'll move to Professor Dilip. Your question?
Yeah. So I think the most of the answer of the differential diagnosis Borna has told you. And along with this, the botryoomycosis and the deep fungal mycosis. These are also very common in this rural setting in India. So these should also be taken care of. And your question, one of the question was you were asking me about my studies from my institution, whether they are case reports or studies. So I would like to say we have 382 patients from 5 districts. A study published in 80. And we have around 150 patients in the first study. So it is basically a collection of data. These are not the case reports only. Okay. So we have collected the data from all over the Rajasthan, and then we published it. You're getting my point? And
yes.
And regarding the diagnosis, histopathology was the key, and then the culture was again done in all these patients. And fortunately, we have the Moderator mycetomatis, commonest organism in our setting. So regarding you were asking about why we are why we are going for the causative agent. So what I feel is, if we know the causative agent, then we will be knowing that it's a culture and it's specificity to the drug. It's a sensitivity to the drug. So We know the itraconazole is effective in a Moderator, yes, of course, but among the few species, it is not at all effective. So until and unless we know the specific organism, or at least we know the trend of the organism in our particular region, then we have the on a priority we can give the whatever the drug we have, for which the causative agent is most sensitive. Okay. And regarding the histopathology, radiodiagnosis, we have all the facility for the including the X-ray, sonography, and MRI. But it might be some center they don't have that. So, so this is there in India. I think it is most of the district center they have a MRI. So in India there is no problem.
Yeah.
Yes.
Just one question to add, Professor Dilip. Is there a plan to do community-based study or mapping in the future in India?
Yeah, it is already undergoing. It is with the help of DNDi, and we are getting the data of last 10 years from 2014 to 2024. So this retrospective study is already on, and we have started, and even my center is going to start in a day or two for the for the feeding the data in that particular app. So we are there, and this is going to certainly help the magnitude of disease and the most common causative agent and the sensitivity of these agents. So this is going to really, I will come to know the burden and how to help our poor patient just by knowing the burden of the disease.
Thank you. As you can see, the issue is for mycetoma in a different region. The causative agents are different and the sensitivity is different. You can see that for South America, completely most of their mycetomas are actinomycetomas. In Africa, we have combination, but dominantly the EU mycetomas. So when it comes to, just to add with what Professor Dilip has said, when it comes to the diagnostic criteria, and actually the most important, the most important evidence we have now is which is coming from Sudan. And importantly, there is the clinical diagnosis, based on the epidemiology, you can reach into decision, quote unquote, if there is no resource. But most importantly, the work ahead is at least to have a basic laboratory diagnostic methods from the KH to the fungal culture. The most important is, especially in Africa, the fungal culture and the PCR. And one thing which is not being utilized, especially which is being used in Sudan very frequently and with a successful result, is the ultrasound diagnosis of mycetoma. And very much they have developed an improved technique to diagnose mycetoma or to assist the mycetoma diagnosis using ultrasound, plus also to assist the, especially the biopsy, the surgical biopsy intake and so on using ultrasound. This is easy, non-invasive, and definitely it will not give us the final diagnosis, the etiologic diagnosis, but at least it will give us whether there is encapsulated thing, whether there is mycetoma and acetomycetoma, and so on. And there is, Priya has posted important information here. You know, one of the advantage which COVID has brought to Africa is there is now, the PCR machines everywhere. And in each country, can we really exploit this opportunity to expand and use them for diagnosis of the NCD is another issue. But we have to also utilize this, the skin NTD laboratory network, which is in Africa, currently in Accra, which has 5 skin NTDs, including mycetoma. So especially for, we may not use this for individual patient diagnosis, but to have an idea what type of mycetoma is going on in our region, each country with the just collaborating with the regional WHO. At least we have to work on utilizing the regional diagnostic center. I'll come to John. John, one question which is coming out from, especially, thank you for your work in this most neglected area with the neglected diseases. One question which comes out from here is, the first thing is, how are you working with the preventions and what are the preventions? And the second question is, I know this is an NGO running project. Is there a plan for integration into the public health sector, especially for the clinical care and also rehabilitation? John. John, can you hear us? I think if John didn't respond, since Borna, since you know also the center, you may jump up to that. Ikai, John Ikai, can you hear us? So Borna, you can jump.
Okay. So with the Lodwar County and Referral Hospital, they are working quite closely with the Spanish team, surgical team from Spain, where they have been conducting. I can see his up.
Sorry, I had a network problem.
Okay. Did you hear our question, John?
Kindly repeat the question, please.
Yes. Well, two questions. The first thing is, what are the prevention strategies you are campaigning for, especially in your patient advocacy? And the second is there a plan for, as NGO, and those all patients, around 90 patients are managed by NGO, is there a plan for integration of the care to the public health sector? And also, is there just rehabilitation? Thank you.
Pertaining if there is a intervention from the, apart from the NGO, actually mycetoma is neglected, truly neglected in Turkana, and we majorly depend on NGO like Suruji and Turkana. I think in June, we had a collaborative meeting between DNDi, Camry, CDC, America, and County Government of Turkana. I think in the due course, they will come up with something to improve the care on mycetoma patient in Turkana.
Thank you. Dr. Augustin and Borna, one burning question which is coming up again and again is the cost of the treatments. The cost of the treatment, even the existing less effective treatments. Is there a plan from the WHO side and also from the DNDi in the horizon to decrease the cost of treatment, or actually accessing those treatments through WHO as essential drug for each country?
Yeah, thank you. You know, if you follow my presentation, I say that in the future, we need free donation for this neglected disease. But still now, it is not possible to get it for free. And in partnership with DNDi and other partner, when we met with our pharmacist producer, we show them first that we need them in a social part of their responsibility to go in the sense when we will arrive to have a free donation. But still now we don't get it. That is a problem. We are working on this. We know for all NTDs that affect poor people population, and we are fighting to reduce the price or to arrive finally for free donation. that is we are still fighting.
Borna, you can add on that.
Yes. So definitely treatment and access. This is the biggest issue we have to look at, even as we look at research and development, because from the work we just did in Sudan within the clinical trial, we were using the trademarked itraconazole from Janssen Pharmaceuticals. And this is because of the known quality. And we are aware that such itraconazole can cost from around 1,500 to almost 2,000 US dollars for the treatment of a patient, which we do understand is quite impossible for most of these neglected populations. There are quite a number of generic itraconazoles that are available. Unfortunately, we are not aware of the quality aspect of this, because part of the expert meetings we've had that the itraconazole capsules can vary. You'd find one with 100 beads, another one with 900 beads. You do not know the pre-qualification process. And we currently only have one generic WHO pre-qualified itraconazole from Chemo Group. So we are currently working with them to be able to understand the market demand within Africa and Asia and all these African endemic countries, to be able to allow them have this provided to these endemic countries. But as with all treatment that is required for NTDs, and especially these poor populations, we need them at very subsidized costs or even donated. So we need to be able to integrate mycetoma in terms of having it within a WHO essential medicines list, also having it pre-qualified in terms of itraconazole and fosravuconazole, ensuring that this is also indicated within the national guidelines and also within the national essential medicines list, to be able to provide these drugs for free or even at a subsidized cost. So we are working on all these aspects in terms of right now being able to have these pharmaceutical companies that can give us quality WHO pre-qualified itraconazole by understanding the markets, and that is required through the epidemiological studies we are doing to understand the burden of disease. We are having regular meetings with the WHO to be able to see how we can progress both itraconazole and fosravuconazole in terms of availability of treatment. But we're also trying to see within our ministries and health systems, because if you do not have a guideline for the treatment of mycetoma, then you're not able to just bring treatment into a country and provide it to particular patients. So all these need to be integrated, because we do understand providing you with a treatment, but knowing the patients are not able to access it is one of the issues we are experiencing the most.
Thank you very much, all the panelists. And as you can see, that just the most important thing from those presentations is actually a way forward also. The first thing is, especially when we are thinking of mycetoma, there is a lot of progress which has gone, especially in including mycetoma as one of the NTD, and also DNDi for taking it as one of its flagship research agenda on neglected tropical diseases. And for all these, one thing which is missing is the data, and especially the epidemiology and the distribution of mycetomas. And this is the big challenge here. The first thing is it's really difficult to do just regional mapping or global mapping for rare diseases such as mycetoma. But for clinician, what we can ask you is actually in each country, at least we have to really report those cases. Yes, there will be a challenge in the HMIS and so on. WHO always asks us actually, even those case reporters, compiling case reporters can come as case series, and then based on the evidence we have, we can go for either community-based mapping or researches. And the other big challenge on mycetoma is, you have seen it on the diagnostic. And currently in most African countries, we are clinically diagnosing mycetoma. And sometimes we can say that we don't know what we are treating. and our treatment is based on the evidence we have from Sudan. And on this, the surgical treatment is not really most of the time included in most treatment setting. And the other big challenge which we need to address as researchers, clinical, is also the management and patient rehabilitation. I think saying this, I will conclude today's webinar. Again, thank you for all the distinguished presenter and also the participant for your patience.
Please.
Okay.
May I add just, yes, as WHO, FDAW, we need really to request to all participants, essentially the researchers, to be collaborative with the Ministry of Health. That is the thing that can help data to be known, because in some places, scientists are working alone and they don't share data with the Ministry of Health, and WHO need the official data that are validated, that are accepted by the Ministry of Health, and then all researchers are requested to collaborate with the Ministry of Health and to be a team. That's a request I catch this opportunity to give to all participants in this webinar. Thank you.